zone?
Airplane.
Airplane. Red zone is for the loading and unloading of patients only. For no passengers. Airplane. All right, so we talk about endocrine, we talk about excessive hot or cold intolerance. So you worry about that. That could be, again, your perimenopausal patient. It could be some patients who have a history of multiple sclerosis, have excessive heat intolerance. We talk about excessive sweating. So this is not somebody who, goes out and runs 5 miles and, well, I'm really, really sweaty at the end. Well, of course you're really sweaty at the end, okay? But if somebody is sitting in air conditioning, then we're worried more about thyroid issues, okay? So are they hyperthyroid or the hypothyroids where they have this hot and cold intolerance? Again, we talk about our polyuria, so peeing a lot, polydipsia, drinking a lot, polyphagia, eating a lot. Typically the 3 Ps go along with diabetic diagnosis. And so the polyphagia, the increased eating, patients won't necessarily recognize unless they're like me and I had 6 Oreos for breakfast. They're cotton candy Oreos. They're really good. They're like crack cocaine. They are. They're fantastic. Only available at Target. Your polyuria, so somebody who's peeing a lot, or polydipsia, patients will actually notice, I'm going to and filling up my water jug like all day long. I'm constantly thirsty. I can't seem to get enough fluid in me. And so they won't necessarily equate the fact that they're peeing a lot because they're drinking so much. So you have to always ask the 3 P questions: polyuria, polydipsia, polyphagia for those patients. Again, any thyroid issues, they might be subtle. Again, remembering thyroid problems cause hot and cold intolerance. They cause palpitations. They can cause weight loss. They can cause fatigue. So again, some of those things are covered in different categories on your review of systems. And Jeff asked me, do you get better about this as you go along? Yes, your first history and physical that you take on a patient will take like an hour. That's normal, okay? You become more fluid with it as you move along. And one thing that I'll kind of take a picture of and post on, because I don't know if it's a required text for any of your classes. There's a little cheat sheet book. It's fantastic. It's a little spiral bound book. It costs about $4. And it's called a Maxwell. And it basically has color-coded sheets, and on one of them it has a complete review of systems. The nice thing is I think the yellow page is all about admission orders, pre-op, post-op orders. It has your cheat sheet. I lived off of that thing for my first year in practice. And it's always nice to carry in your pocket because it has like 3 extra pages you can write all your own little cheat sheet notes on for dosages of medications, for example, that you use all the time. So that you don't have to be constantly turning on your phone. You can literally just flip to your page in your book. So I'll take a picture of it and post it on your announcement on your history taking course. So we talk about allergies or immunological issues, so any history of allergic rhinitis, so patients who have a runny nose or allergies, but they only happen maybe in the fall or in the winter. You have to kind of look at what's blooming. Again, that patient might not report to you that, I take my Claritin or I take my Zyrtec, or because they could just buy that over the counter. They don't necessarily deem that to be a medication because it's not prescribed by a provider. Another big one that they don't deem to be a medication prescribed by a provider, baby aspirin. Okay, so always got to make sure that you note whether the patient's taking a baby aspirin, 81 milligrams. Any history of asthma, any history of immunotherapy. So if they've had a history of MS and they've had IgG therapy, if they've had a history of myasthenia gravis, and they're on Mescaline. Those are big ones. Typically, those are ones that are actually discussed and documented within medications or past medical history. Yes. Usually birth control they mention, but having said that, if they're on an IUD, they will tell you it's implanted, but they may not know what they have in them. So like a copper IUD is a non-hormonal IUD, and they may not know whether they have an indwelling IUD that's hormonally based or not. So that's where you kind of have to delve a little bit deeper on the medications. When we talk about frequent or chronic infections, because if somebody is chronically ill, it might just be that they have, as we always used to call it, poor protoplasm, that they just kind of just aren't the healthiest of characters and don't have a healthy genetic line. But the other issue is it something environmental? Is it something in their house? Is it something where they work that they're chronically being exposed to colds and coughs and flus? Okay, do they need to just change their environment? Is it something actually going on within their home, physically within their home, that's making them sick? Okay, We know that around hurricane season every year, everybody gets concerned because of what? Carbon monoxide. So carbon monoxide poisoning, why? Because of generators. People put generators in the house and they don't vent it to the outside world. Okay. They'll wonder why they come in with a headache. Might be the fact that they were breathing carbon monoxide all night long. HIV status, if they're known positive when they were diagnosed, whether they were compliant, again, especially for that patient who is HIV positive, who does have now chronic recurrent infections, are we talking about somebody who has now progressed to an AIDS-defining illness? Okay. Psychological, so we talk about mood, anxiety, depression. If they have had a history of depression, if they've been on medications in the past, is this something that's essentially a recurrent issue for the patient, a familial issue for the patient, because we know a lot of the issues like bipolar disorder, schizophrenia, depression actually run in family lines. So again, you're covering that kind of in the family history, but you're also capturing it in the review of systems, just in case patients didn't bring it up. And again, throughout this process, there's a lot of redundancy, and it's mainly to make sure that if your patient doesn't want to tell you something, or they maybe forgot to tell you something, you still have a way to capture that data. So explain that you're going to be, now as we're transitioning and we've finished this. You're now the mic of this room. There we go. There's Mike in the other room, and he actually does all the stuff for me. Mike, big Mike. So as you're transitioning to the physical exam, you're basically explaining to the patient, well, now we're going to do your physical exam. I'm going to take a look at you. If you need them to disrobe, always a good idea to step out of the room to tell them exactly what you want them to put on. If it's a female patient, you're doing a breast exam, the gown is open down the front, drape the other drape over your waist. If you want them to normally put a gown on, you put the gown on, have the opening in the back for me. Explain that to your patient. Otherwise, you never know what you're going to walk into. Trust me. Never know. Okay. If you think of something else to ask about the HPI, again, or about the review of systems as you're looking at your patient, go ahead and ask your patient. Okay. Make sure that you're always thinking back to what brought them into the office today, so that you're thoroughly exploring and addressing their chief complaint. Okay. You can blend that review of systems straight in. So as you're doing a cardiac exam, always start to get in the habit. And I noticed this with a lot of the second years as they were going through their Medi simulation OSCEs, that they had their stethoscope in their ear, they were listening to the patient asking a question, kind of popping their one earphone out on one side so that they could listen and get the answer, putting it back in and going back and listening to the cardiac exam or listening to the lung exam. So you want everything to be very fluid for your patient. And the other nice thing about blending that review of systems into your physical exam is it allows for that continued dialogue with your patient. So you're not just like, well, I'm going to do your physical exam now, and you're going to sit there naked. By the way, the room is 65 degrees and you're freezing cold, and you're just sitting there and they're just sitting. Okay, take a deep breath. Okay, so you want it to be very natural and easy for your patient to make them feel comfortable. And one way to do that is just to continue to talk and to continue to have to ask them questions. So you always want to get in that habit of looking and asking and listening. So again, you're constantly kind of reassessing why they're here, reassessing if there's something else subtle or little that's going on that they're not talking to you about. Different scenarios, when we're in the hospital, typically we have a shorter time frame. We're typically talking about a little bit more of an emergent or urgent situation. So you always want to define those roles. You want to tell the patient, I'm going to do your physical exam, but the nurse is going to start your IV, and just talking to them and telling them what's happening around them. Because there might be, especially if you're in the emergency department, there might be 5 other people who are working on that patient at the same time. So-and-so over there, they're going to be asking some questions about your health history. I'm going to listen to your heart. Feel free to talk. I'll just listen to your heart through your answers. And, Joan over here is going to get the IV started for me. As long as you're explaining things to them, you'll start to see their heart rate just naturally improve. Okay, at least you're not adding to their anxiety. Very different when we talk about an office setting. So in an office setting, I'm going to perform your physical exam. What we're going to do, we're going to monitor your blood pressure. We're going to have you monitor that at home. We're going to give you a blood pressure machine or give you a prescription for one. I want you to write the recordings down. We're going to come back in 2 weeks and look at that again. So again, involving your patient in the plan of care. Okay. not only allows them to feel more comfortable, it allows them to be a little bit more responsible for what's going on, because 9 times out of 10, not all your patients come to you for a trauma that was somebody ran a red light and T-boned their car. 9 times out of 10 when they're coming in, I have a cough. Why do you have a cough? Well, I've been smoking for 40 years. Okay, so let's place some ownership on that, and let's kind of involve them in their care. When we close everything, when we close with the patient, you always want to say, is there anything else? And I always used to ask patients, do you think we got everything, or am I missing anything? And it was just kind of gave them the ownership. And I had patients sometimes say, well, yeah, I wanted to tell you about this. And it would allow them to tell that additional story or that little component of their HPI. It's okay to admit to a patient or to expose yourself to the admission that you may have missed something when you're talking to them, okay? So certainly just, is there anything else you wanted to talk about today? Anything that you think that I missed? Also a good way to look and talk when you first start doing your first admission orders through whatever service you're on, through any type of hospital setting, ER setting. I always used to take all my admission orders to the nurse who was taking care of the patient and have her look at them. This was, of course, many moons ago. We used to write everything down. But I would take her the orders and say, do you think I missed anything? And number one, it always made you nice friends with the nurse, which was always a good thing. Number two, it typically avoided a 2 a.m. phone call to me, because if I had missed something, I just went ahead and wrote it then, and then I didn't have to be woken up in the middle of the night, okay? Always be prepared for any answer that they give you. If you're going to ask the question, trust me, some of them are going to be nice and blunt with their answers. So just always be open to whatever answer they might provide. Remember to keep that poker face and to always remain objective when we talk to our patients. If the patients have asked, you know, hey, did you get my lab results that came back, were supposed to be back a week ago? Don't be like, I don't know. Just be like, let me check on it. If you don't know, go and check, find out, okay? I don't know, or I'll get back to you if, you know, if they're in an office setting and I'll get back to you in a week, that's not an appropriate answer. They need an answer before they're leaving, because half the time the reason why they came to the appointment was to get the results. So you should know that going into the room before you're even seeing the patient. Don't walk in unprepared. Share your differential or your thoughts. So this is what I'm going to be looking at. These are the studies that we're looking at. If you're truly worried about cancer, tell your patient, okay? Most patients do fine knowing what's going on with them or knowing your concerns. They will come up with a huge, their own differential diagnosis in their head if you don't tell them. And they will create something far worse than you could have ever diagnosed them with. So always be upfront with your patients in terms of telling them, hey, listen, I don't like the fact that you have blood in your stool, and these are what it could be, you know? And if they say to you, well, do you think I have cancer? Well, you know, you might, but in all likelihood, it's an ulcer. In all likelihood, you have hemorrhoids, okay? You can, by just stating the simple things of what you're concerned with, decrease their anxiety substantially. Okay, so always tell them your differential diagnosis. What do we not do? So, you know, if you're friends with your patient, it's one thing. We had a couple patients that would always come in, and I knew them for years. So it was fun to just kind of banter back and forth with them, because it really helped them to relax, and they typically opened up to me more. But if you're meeting a patient for the first time, or certainly if you're in an ER setting, you can't be like, oh, you're my last patient of the day, and I'm so excited because I'm going to go close on my house now. Okay, they don't care. Okay, everything that's going on with your life, they really don't care. It's not the appropriate time to be telling your patient that. It's one thing if you have a friendly rapport with them, to have a little banter and dialogue. And I always liked when I had my older patients come in, especially all my World War II vets, because it was always fun to talk to them about what ship they had been on. But again, that banter and that dialogue for me was a way to get them to open up and tell me why they were really here. So it allowed me to establish a connection with them. We want to educate our patients, so we talk about having high cholesterol and give them an option. Do you want to try diet and exercise? Do you think that that's actually something you can do, and we can reassess this in about a month and see if your numbers are better? Some of your patients will be completely honest and say, no, I'm not going to do that. So let's just go ahead and start the medication. Make sure that, again, you're involving them with the plan of care. You can always tell them, I know you don't have insurance right now. We talked about in the social history, knowing whether someone's insured or not with regards to medications, but especially if we're talking about preventative measures. There are various centers around town that you can become familiar with. I know you don't have insurance, but you need a mammogram. I know it's really expensive here, but they're having this service next month at this facility, and the mobile mammogram wheel will be here, okay? Or you can go to, I think it's called LifeScreen. Yeah, LifeScreen. You know, or hey, I'd really like you to have that carotid study done. And if you go to LifeScreen, you can actually get all these 4 different tests done for $135. Do you think you can go do that for me? So you want to know your options around town and still allow for that preventative care for your patients. I love, you know, patients that leave AMA. That's fantastic. But they can decline anything, okay? They can decline anything. You always have to have the obligation to tell them, if you get worse, please just, you know, tell me that you're going to come back. But they're signing out against medical advice. Half the time when they sign out against medical advice, we are nowhere to be found because we've already seen the patient and left, and it's essentially the nursing staff who's typically having to deal with the patient leaving against medical advice. A lot of times that's not something that you come back to the hospital and try to persuade your patient to stay. I have actually Baker Acted a patient, which is keeping them against their will, one time because they had a head injury and they wanted to leave against medical advice. So I Baker Acted the patient, kept him there for 3 days. They didn't like me very much, but they were fine, you know. So there are situations where the patient's not allowed to leave, and typically head injuries are one of those situations because you can prove that they're essentially not in the right state of mind to make that decision. We want to make a list and prioritize. So again, what brought them into the hospital, you want to make sure you cover first things first. Whatever brought them into the office or the hospital setting, that's the patient's priority. You take care of that first. If you catch any additional things on your review of systems, you kind of keep a running tally and list of things that need to be done long term in terms of screening, in terms of laboratory studies, all the things that need to be ticked off that don't necessarily need to be done at this office setting, okay, but maybe need to be accomplished in the next 3 months or the next 6 months. What needs to be documented? So not everything has to be documented. So remember that your medical record is a legal document and it is legally discoverable, meaning that if the courts subpoena that document, it can be held against you. Not held against you, okay, no, but held against the patient, okay? So if they've ever been convicted of a felony or a crime, misdemeanor, or anything like that, if they have some really weird, you know, sexual practice or something, if it doesn't contribute to the history of present illness, if it doesn't contribute to the review of systems or what is going on with the patient, it does not need to be documented, okay? So just because it's interesting or weird or you think it's weird does not necessarily mean that it needs to be documented in the medical record, okay? Basically, you want it to be that if your patient came and read that medical document, which they have the right to, that they would not find anything that they would be concerned with, okay? And a lot of times your patients will actually request a copy of their medical records. And I had one patient come to me one time and she was, not at me, thank God, at the cardiologist who had come and seen her in consultation because the cardiologist had documented a complete physical examination and had never touched her. So if you didn't do it, you don't document it. And also, if you don't need to document it, don't put it down, okay? Avoid any diagnostic words like the patient appears depressed or the patient appears anxious. Go with words like the patient's sad or hopeless, truly unless they have a diagnosis of depression, because you don't want to throw your own opinion in terms of what they are like unless we actually have a diagnostic or actually have a diagnosis and a ICD-9, soon to be ICD-10 code to go along with that diagnosis, okay? And document things that other healthcare providers need to know. There might be something a little unique, like you might want to tell the person who's walking in as the pulmonary consultant, hey, by the way, the woman sitting in the chair next to the patient, that's not his daughter, that's his wife, okay? Because I've done it multiple times. But does that need to go into the medical record? No, okay? But it's nice when you walk into the room that you're addressing everybody appropriately. And certainly if you've walked into the room and put your foot in your mouth, you don't want somebody else to do that as well. My oldest patient I ever had, or I should say age range ratio, was she was 49 and her husband was 94. And he was the healthier one, okay? We operated on him so that he could take her dancing. So, but trust me, so is this your daughter? I did it. But then you walk out and you tell the next provider, by the way, that's the wife. Oh, okay. Little helpful hints, okay? And then always when we talk about actually giving that information to another provider, who are we talking to? So are you talking to another PA? Are you talking to another colleague? Are you working in the emergency department and you've got 5 patients that are left over and you're passing those patients off to a colleague? That's going to be a very different story than when you're talking to your attending or when you're talking to a consultant, okay? So if you're the attending, if you're the primary or internal medicine team, but you're consulting somebody for orthopedics, they probably don't need the laundry list of everything that you would give to your attending. They may not even need everything that you would give to your colleague, okay? Why are they here? 56-year-old fell, femur fracture, no known allergies, not on 8 blood thinners, INR 1.4. That's really all the orthopedic surgeon really even cares to know, okay? Broken bone, fix it. That's all they want, okay? My brother's an orthopedic surgeon, I could say that. So down and dirty in terms of your consultants, only go to their system and tell them what they need to know. But when you're talking to an attending, you would need to give more of a dialogue about what was going on with the patient, kind of give them more of a cumulative picture of what happened with that patient. So again, we go with the opening statement. So your opening statement is, this is a 26-year-old female who was involved in a motor vehicle accident today. She presented as a trauma alert. Okay, opening statement. And then when we talk about the illness narrative, you can talk, she was the driver in the car, she was T-boned on the passenger side, there was no negative loss of consciousness at the scene, she was awake and alert when she presented here, she was complaining of pain in her right lower extremity, x-ray actually revealed a femur fracture. I've already got the orthopedic surgeon called. And you could tell that to your attending, okay? You can go through the patient profile. She's a non-smoker, she's married, her husband's actually in the waiting room, she doesn't drink, she's got 2 little kids at home. You talk about the physical exam, very brief in terms of if you're talking about a trauma patient. Well-developed, well-nourished, 26-year-old female, appears her stated age, vital signs are currently stable. Physical exam is essentially negative with the fact that she's got her femur sticking out of her leg, okay, sticking out of her thigh. When we talk about laboratory studies, your laboratory studies would be like, what is her complete blood count? You know, what is her CBC? Her white count is normal, H&H, her hemoglobin hematocrit is stable at this point at 11 and 33. Platelet count is 204. So you go through very briefly everything that needs to be done. Then you're, really for this patient, there's no differential. Her femur's broken or her femur's broken, okay? Femur fracture or femur fracture. And then your plan. Orthopedics has been called and they're gonna take her today for an open reduction internal fixation of the femur. Very quick, very easy. Okay, walks you right through exactly what's happening to the patient. But again, that story, even though you always follow about the same format, changes a little bit differently if you're talking to your attending, so it's more expanded. Even a colleague is potentially more expanded than when you're passing that patient off or just getting a consultant on the phone. Because your consultant literally has 2 minutes on the phone for you to tell them everything that they need to know. And truly these days, the nursing staff wants it to be provider to provider. So either the PA talking to the physician or the physician talking to the physician in terms of what's going on with the patient. Please don't put your nursing staff kind of to be the middleman to answer questions that they may not have the knowledge to answer, okay? Remember, they're just going off of what the night nurse told them, which was just a snapshot of the last 12 hours. You cumulatively know what's going on with these patients. Okay, so let's review real quick before we get to our fun quiz, which will go very, very quickly. I wanted to just review what assignment 3 is so that we can kind of talk about that. Okay, so on assignment 3, so we go back to assignment 1, we take the chief complaint and the history of present illness, and we expand upon it. Basically, whatever notes I gave you back on assignment 1 in my purple or black pen, I want you to make those corrections. I have a copy of everybody's, so if you think I'm not going to look, you're not thinking. So I want you to make all those corrections. They should be reflected in that chief complaint and history of present illness, but you don't have to build a new one. If I wanted you to expand, if I wanted you to ask more questions, if there were other associated symptomatology that you entered and I asked, well, what about this and what about that? I expect you to expand upon that. I want you to add a past medical and surgical history, which is original. So I don't want you to take what you've used in assignment 2 and simply copy and paste it into assignment 3. And then I want you to add medications that would actually support both the medical and surgical history. So if you're going to give them a history of hypertension, then I would want you to give them the appropriate medication that would go with hypertension. If you're going to give them depression, give them a medication that actually treats depression, not a medication that treats bipolar disorder. Okay? So then we're going to add a family history, allergies, a complete psychosocial history. Some of you did that in assignment 2. That was a little bit more than you needed. So if you did it in assignment 2, I just wrote you notes of what I want, but it wasn't really added into your grade. I just kind of gave you little cheat sheet notes. Review your prior lectures, textbooks to ensure you have all the appropriate information. So pertinent review of systems that you would have asked because of what the HPI was, I want in the HPI. So if they came in with abdominal pain and you didn't ask about nausea and vomiting, that's a problem. Okay? If they came in with shortness of breath and you didn't ask about cough, that's a problem. Okay? If they came in with pain in their shoulder and you didn't ask about the other shoulder, or you didn't ask about arthritic issues in general, that's a problem. But do I want you to go through a complete review of systems? No. That will come at assignment 4. Okay? So really each assignment is to build upon each other and to not be a whole lot of information that you have to regurgitate every single assignment. When you do your past medical, surgical history, everything that goes in the past medical history, like immunizations and childhood illnesses, those should all be bullet points. The only part in any history that's truly a dialogue is the HPI. Under past medical history, you don't have to say the patient was diagnosed in 2010 with hypertension and was treated with this for the hypertension. And then under medications, also put atenolol. Okay? In the past medical history, you put hypertension, if they even knew a year, 2010. But let's be honest, half of the time the patients are diagnosed with a condition, it was going on for a while before that. Okay? So we don't necessarily need a year, but I need a diagnosis. So I put up here last week, good luck if you can read my handwriting, kind of a cheat sheet. So in terms of past medical, past surgical history, allergies, medications, they should all be bullet points so that when your consultants come through, they see past medical history, hypertension, COPD. Past surgical history, appendectomy, what year, okay? And I don't need to know that they were hospitalized for the appendectomy. I know they were hospitalized for an appendectomy. It's kind of illegal to do it someplace else, okay? Medications, lisinopril, and if you know a dose and how often they take it. Family history, we list. Allergies, penicillin, what was their reaction? Penicillin caused hives. Peanuts causes anaphylaxis. So you don't have to put past medical history that they have an allergy to peanuts and they have an EpiPen, because I know allergy for peanuts should be under allergies and EpiPen should be under meds. Okay? Remember, this is so that when you're consulting physicians, when your team comes through, they read the HPI, but when they come through, they want to be bam, bam, bam. They want to look at stuff and know this is what their diagnosis is, this is what they're treated with. You don't have to tell me they have hypertension and they're treated with lisinopril and then put lisinopril under meds. I know that lisinopril treats hypertension, okay? So you don't have to double things up. The whole goal is for when you read through an entire history and physical, basically you're getting the bullet point issues very, very quickly, and those should be gleaned in about 2 minutes. The HPI is kind of more of the patient's story. Therefore, it's a dialogue. So when we talk about that, it should actually be a dialogue. It should be complete sentences, okay? Don't start a sentence with a verb. Let's remember proper English, okay? So make sure that you're using proper words. A couple other words that I noticed people were using, endorses. Nobody endorses. I mean, I endorse Diet Mountain Dew, and I wish they would endorse me for crying out loud, But the patient complains of, okay? The patient doesn't decline something. Your credit card might decline you, but that's a whole different story too. You deny. So a patient basically either complains of something or denies something. Okay? Yes.
So, my assignment too, basically they had like no surgical, no medical, almost nothing.
That's fine.
You just put none or no or negative what?
You put either none or denies. And if the patient has had a history of an appendectomy, you don't have to put no other surgical history. If you only put an appendectomy, I am gonna assume that they don't have any other surgical history, so you don't have to tell me that. Yes. One and the two.
Bulleted as well.
Yes. Married, you know, married, tobacco use, alcohol use, you know, Jewish, whatever. Bulleted. Yes.
For the medications, you want like dosages and how many times per day, or if they take it as needed and stuff?
Yeah.
Yeah, you want that as well?
Yeah.
And then do we get like one draft submission against you, or should we stop in your office?
I would stop on my office. The only day I'm not here is tomorrow. I'm here all day Friday. And Monday, I'm here, but I'm with the AD students suturing all day. So I'll be here, but I'll be busy, but I'll be here. Here, and then here, and then there.
Back to the social, if they like smoke and they say no, do you not include it or you say smoke denies?
Denies. Yeah, denies.
Wait, do you say smokes and then denies, or do you say denies?
You can say tobacco use, denies. You know, because then you're basically, when you say that, you're saying they don't smoke, they don't chew, they don't vape, they don't dip. Right?
I think he was saying like you could tell that they smoke, but they deny it.
No.
Okay.
No. Yes.
Is there a particular order in the bullet below the HPI that makes the most sense? I mean, you do.
I always do past medical, past surgical, allergies, meds. Those four are my top four.
Okay.
You know, because you know the social history. Let's face it, you have to document it. Honestly, a lot of this stuff in one of our lectures coming up will be about like essentially Medicare and Medicaid billing. So you have to document some of this stuff, and some of the stuff actually becomes important. But do people actually read all that stuff? No. So they always read those first four:
Okay. So
past med, past surge, allergies, meds. George. Abbreviations I'm okay with if they're common abbreviations. So like hypertension, HTN is only hypertension. But if you're looking at certain abbreviations and they've got 5 other things it could be, you better spell the word out. We had something over here and then I'll go over here.
under
Immunizations.
do you just put current, or do you list what they
Up to date.
up to date?
You know, like and if they happen to have a tetanus recently, thank God I had mine last year. Tetanus 2014.
Or like TB, whatever year it was?
Well,
That
TB is
year
not,
was
that's a test.
Okay.
So it's not an immunization. So you really don't need to document that they've had a TB test anywhere.
Those are-
If you're a healthcare provider, we need to know that for licensure, right, within a hospital. But you don't need to document that in somebody's medical record. Uno momento. Yes, ma'am.
What about like a woman with sexual history? Like, would you always put that in there, or just kind of like whenever they?
I don't always put that in there. Honestly, you know, you can put if they've had, you can put gravidae, but typically that goes more so in a well woman exam, a primary care, internal medicine. So if you've put your patient in the ER, you shouldn't be giving me an obstetrical history. So think about your setting in terms of where you put your patient in the HPI.
And what about like mental cycle stuff?
No. Again, why are they there? If you're giving me somebody who's got acute onset of right shoulder pain because of a fall, you know, are you really asking them when was your last? You might be asking them when your last menstrual cycle is, but are you having any dysmenorrhea? You know, those questions are going to come in your review of systems, which I don't want yet. Pertinent positives and negatives. Was there another question? Are you guys just trying to get out of your quiz? I don't know. I saw an equal yes and no head shake.
The immunology report goes in past medical, like if you're for all their shots and stuff. Like different.
What was
What she was talking about shots and everything, like when you put up to date, that goes in past medical history.
it does, but it goes as a separate bullet.
Okay.
You know, immunizations, up to date. You know, refused flu vaccine. If you wanted to put that. But knowing, you know, your normal population that would even be offered a flu vaccine, we're all offered it in here because we're all healthcare professionals now, you know, but the majority of the population walking around doesn't even get an option to refuse a flu vaccine. Okay. Any other questions? Yes.
Quick, is MVA okay for motor vehicle accident?
MVA? Yeah. Because really MVA is MVA. Yeah. MVA or MVC. So motor vehicle accident, motor vehicle collision. Those don't go for anything else. We good? Quiz time?
Yeah.
So excited. Oh, one more question. Shocking.
What you have on board there, allergies?
Yes.
Should it really be up to us for that?
Yeah, so it should be 1, 2, 3, 4.
Okay.
Yeah. We'll do this. Okay. Yeah. Okay. You know, and like if grandpa died at, you know, half the time with regards to grandparents, people don't know what they died of, so don't belabor the point of, well, what do you mean you don't know what your grandfather died of? You know, if you ask me that, my grandfather died when my mother was 11. I don't know. I never even met the dude, so I'm sure he was very nice. All right. Let's have fun. And then as you're like leaving for lunch, we'll pass out the assignments. All right, where is my thingy? There it is. I'm losing.
Are we just doing HPI, PEG, lymphoma, or colon, or are we doing the whole?
Pardon?
Are we doing allergies and medications as well this time with
Yeah.
family history and?
Yeah. But just really no detailed review of systems. That actually will come at assignment 4. Okay? I don't want you guys to get like, you know, get writer's cramp or get carpal tunnel before you even make it out of this semester. Oh, BTW. Like, how, you know, look at how you're writing things. And first of all, they should be complete words. Like, don't write PT for patient, write patient, okay? Like, start the sentences with the patient. We're not robots. We're not like, patient states, the patient states, right as you would talk, okay? And the other thing, what was the other thing? Oh, spell check. Spell check does not catch everything, people, okay? There are multiple ways to spell certain words. How do we spell sore or sore throat? How do we spell it? S-O-R-E. How do we spell sore if we're going to go flying? Amen. Okay? Read your document. Why do you think I use my father? My father's not an option for you all. He will not edit your papers. But have another set of eyes, look at your stuff, or take a third and 10th look at it for crying out loud. Because I will. He is not up there. He's too expensive. He can be bought like me, but he's too expensive. All right. Let me grab my cheat sheet here. All right, we got about 10 minutes to get through this. We got to get through it quickly and efficiently. And again, just because you were called up here before does not mean you are safe this time. So, this time we're going to go, I'm going to give you the questions that you need to ask. So I'm kind of giving you a little cheat sheet. Isn't that nice of you? Okay, so for location, come on down. Oh, no, you're asking me. Okay, so I'm telling you that my right hip hurts. Come on down. Oh, age. I'm 24. I'm a 24-year-old female presenting to the office with right hip pain.
How's it going? My name's Todd.
Very nice. Good move. Duly noted. Okay.
Describe having right hip pain.
Yeah.
Where at is that?
It's kind of like right on the side, and it goes a little bit around the front of my hip.
You said the front of your hip?
Mm-hmm.
Does it happen throughout the day, or just event that triggers it?
Getting ahead of yourself. So it kind of goes a little bit into my leg, like my upper part of my leg. You're done. Angela? Angelina?
Hi, so when did the campaign first start?
You gotta go with character, honey. Character.
Oh, okay,
Oh, they're in random order, by the way. Just to make it fun.
how would you characterize the campaign as being like?
It's just, it's like this toothache pain and it just will not go away. It's like deep.
On a scale of 1 to 10?
You've gotten ahead of yourself. All right, David. I'm being nice this time. I'm giving
Sorry.
It's like a cheat sheet.
So this pain in the right hip, when did it start?
A couple months ago, and it's just driving me nuts. It just won't go away.
Did it come on gradually? Did it happen after some kind of injury or fall?
No, I didn't fall. Nothing really happened. I mean, I run after my 5 kids like a crazy woman, but aside from that, no, nothing that I really remember.
Social talk about
I forgot I made myself 24. And I don't have 5 kids.
So does the pain go, you said it's in your upper hip,
Mhm.
it's your leg, does it go anywhere else, like up on this back, do you feel it in any other places in your body?
It doesn't go into my back, and it doesn't really actually even go like past my knee.
So it's like your entire front leg,
Entire front leg, yeah.
okay?
Okay. Did we do duration or we did onset?
Oh, on set. Okay. So how long has it been having this pain?
Well, since it's gotten there, it hasn't gotten any. It's been about the same, and it's just like it tends to get worse throughout the afternoon, probably because I've been running around more. And then if I can kind of lay down, it seems like the intensity of it waxes, wanes a little bit, but it really hasn't. The duration of it, it's been like this for months. I had some similar stuff when I was expecting, but with each of those episodes, basically the minute I delivered, everything went away. Sam.
Okay, so this hip pain has been happening. Were you doing anything particular about a month ago when it started?
Mm-mm. No, it's been there for a few months. Yeah, yeah. No,
You're just running after your kids and
just normal
nothing
stuff.
out of the ordinary?
And this is like the same as when I was expecting, but it just seems like it's worse and it's just not going away. What's the big word I want you to ask?
pregnant.
Not, I'm not pregnant again, guys. 3 weeks ago. Yeah. What was my last menstrual cycle? 3 weeks ago. Have I had any trauma to the hip? No, I mean I fell, maybe about 4 months ago, but this only seemed like it started like weeks after that, so it didn't even seem like those were related. That's why I didn't even, when you asked before, I didn't even think about that actually. All right, somebody got ahead of themselves, and they helped you out.
So it radiates to the front on a scale of 1 to 10. What's the pain?
It's about a 6 or a 7. And had it easy.
I guess I asked some of your past medical history.
Mhm.
Had any major surgeries in the past?
I had one, my medical history. Not my surgical history.
Oh, your
My medical history.
okay. Have I guess as far as your medical history,
have you had any, do you have any major illnesses or childhood illnesses as a child?
No, I had chickenpox like everybody does. I don't know. think I was like 8 years old when that happened, but otherwise I've been very, very healthy. I've never had any medical problems. Um, I'm taking like orthotricycline, a birth control pill, and I take a baby aspirin every day, and I've tried like some Advil for this, but it hasn't really helped at all.
Are you allergic to
Oh,
So I know you said you took Advil for the pain. Is there anything else that you did?
I tried icing it a little bit. That really didn't help. So then I tried heat. I actually went to a massage therapist that my friend recommended a couple times, but even that didn't do anything.
All right. Do you have any allergies, any medications, or
No, I kind of get stuffy like in the summertime when the grass is blooming, but nothing to any drugs. I'm nothing makes me sick really.
never had an allergy reaction?
None.
Okay, so is there anything that makes it worse?
Yeah, like when I can rest when my kids rest in the afternoon, I do better. But then when they wake up and they start running around, and I have to pick up my youngest, is just 2. Start having kids really young. When I have to start picking up my youngest, it gets worse.
Okay, do you normally hold your kid on that side?
Good question. Yes, I do.
Okay, so you're right hand, so you usually use the right side of your body.
Yes, I do. I didn't even have that written down. All right, we're good.
You ever had any surgery?
I had a C-section with my last child. Otherwise, all the other kids were vaginal deliveries. They were fine. But no other, all my other innards I got. All my other inside organs are still there. Mm-mm. You can start asking questions as you're walking, because I know we're running late.
Do you drink any alcohol or do you do drugs?
I drink a glass of wine with my husband on the weekends, just like Friday and Saturday night. No, I haven't done any drugs.
Do you smoke?
No, no,
Tobacco, chewing tobacco,
no,
vaping?
no.
Oh, are you single or are you married?
I'm married. I did say my husband's still gonna ask though. Some people consider themselves married and they're not married. Why do you have to ask that, right? Because it goes to next of kin in terms of medical decisions. So am I married? Yes, I've been married for 8 years.
What are you?
We got married in Tennessee. All right, you're good.
Are you sexually active?
Yes.
With only one partner?
Yes, only one baby daddy. They're all from the same. Yes, they're all from the same husband.
All right.
How many husbands? I only have one husband. Ooh. Sister in law. All right, I'll go check with her. Anything that you would have asked that she didn't ask, you can ask as you're walking. What do I do for a living? I am a stay-at-home mom, and I actually do medical transcription from home, believe it or not. Those 5 kids really give me enough time to actually do some medical transcription. I'm Catholic. All right, he's done. Eddie, come on down. Lopez, you picked the short straw today. And you're welcome. So what's going on with our patient?
Patients, 24-year-old female presenting the right side hip pain. Pain's persisted it began a couple months ago. She's had no falls or injuries. It's worse in the afternoons. Slightly better after laying down and resting. No traumas, no past surgical history other than C-section. I'm not allergic to any kinds of medication. Takes baby aspirin. Icing didn't help, heat didn't help, massage therapy didn't help.
Remember, I'm allowed to be out of order as a patient. You gotta tell me the right story. I'll let you off the hook. Okay, so remember, your patient can jump all over the place. You have to be able to, and that's why, like, it's good to have, especially with the history of present illness, whether it's this mnemonic, there's about 7 different mnemonics that you can use that get you through duration, onset, character, location, intensity, events, palliative, provocative, all those things. If you kind of have a cheat sheet written down and you're filling it out, that way when you're going and you're actually giving that information to another provider or to another colleague, it gets you in that habit of telling it in the right order. Because your patient's going to be all over the map, but you have to actually present your patient in this kind of nice little concise package. You essentially have to sell that patient to your next person. Remember, especially if you're working in the ER, you're clocking out. You're like, I'm out of here. You got crazy in bed 12. But you got to tell them what crazy's doing. Okay, if she's this 24-year-old who's been married for 8 years, she's got 5 kids. Okay, so you have to walk through the story in about 2 minutes to be able to tell that entire scenario to the next person who's taking over her care. Okay? I don't know. I was like, I was making it up. Half the stuff I was making up.